who will be kicking us off with a PowerPoint.
And the most important part of the body, which is the eye. So, I'm just going to talk, I just pieced together some common questions that patients ask me in the office. And this is still out there. Is eating carrots, is it good for your eye health? And the short answer is not really. Disappoints you all. The greatest nutritional benefit of eating carrots is probably, besides fiber, is having vitamin A. Vitamin A actually is useful in eye health, but it's really more of a third world and historical issue in which you can have extraordinary vitamin A deficiency, develop very bad eyes, lose your vision on that basis. But this is not a practical problem in the United States, or really. Can I do anything to prevent becoming nearsighted? So that's so I don't have to wear glasses. And the traditional answer in ophthalmology is no. It's actually been some studies which actually suggest now there is something you can do to not become nearsighted. It doesn't apply to actually anyone in this room. Perhaps it applies a little bit to Eric York and his patients. But there's some interesting work in terms of preventing nearsightedness. And nearsightedness is really epidemic in the world. About a third of the population starts using glasses for distance, and this is particularly epidemic during the Orient. And it's like, so why is it becoming more and more common? And the thought is that the studies that show this now is that it's actually the lack of being outdoors. And so if you want to try to help prevent your child from becoming nearsighted, it's good to send them outside to play in the outdoors instead of spending time inside watching TVs, looking at their various computer devices. So it's really not actually using the devices so much, it's thought to be actually a lack of exposure to sunlight and outdoors. Questions like, can I do anything to not need reading glasses? That's sort of the next question. Maybe applies to everything in this room, and unfortunately the answer is no. So, right, Carl was cheating on his, trying to cheat on the eye chart, but he couldn't. So he wanted to pass the eye test, but he couldn't read his little crib sheet on his hand. So, is there a role for vitamins in eye health? Can I take any vitamins to make my eyes better? And actually, there's a widely marketed eye vitamin that I get questions all about. So, should I take those eye vitamins, which are actually fairly expensive, no surprise. And the commercials that have come out are rather misleading. Like they suggest that if you want to do something good for your eyes, the eyes are the most important part of the body, you should take eye vitamins. So this is the product that's typically marketed. And actually the reality is there's some, one of the few actually benefits of, proven benefits of taking vitamins is for eye health. But it only is for a specific form of macular degeneration. So if one has these findings, so as ophthalmologists, we actually do recommend people take vitamins if they have the clinical findings for which this ARED study was done. So it's literally it was a large study of thousands of people who had an early form of macular degeneration, and what the studies show is it reduced your chance of the macular degeneration getting worse if you took a particular combination of vitamin C, zinc, lutein, zeaxanthin, and that's what this formula is. And it's not, doesn't mean you see any better. It just makes it less likely that you're going to have additional problem. But it's only a specific form of problem that you need to really be told by an ophthalmologist that you need to take them. Otherwise, total waste of money. So, should you wear blue blocking? This is marketed. People spend lots of money on blue blocking glasses to work on the computer, and the evidence for this is essentially non-existent. So the answer is no. It doesn't do any good to wear blue blocking sunglasses. No specific computer glasses have proven to be of any particular age. Should I wear sunglasses, or is the sun bad for my eyes? Well, I actually mentioned before, maybe for children the sun might be good for your eyes, certainly. But the sun may certainly not be good for your skin. But should you protect your eyes if you're going to be on the sun all day? And there's actually, so I won't say in general no, but one form of cataracts is related to intensive sun exposure. The study of sailors, people on the ocean, getting huge doses of sun, they are prone to a particular form of cataract, which is not the usual cataract that we operate on, but it's still, it's certainly no downside of wearing sunglasses, and might give some limited benefit. The human lens, which is, that's what the cataract is, represents a clouding of the human lens, actually blocks most of the, I'll say, more harmful elements of sunlight from getting to the back of our eyes. So, but you can wear sunglasses. And this is another common question we're asked: is what's the difference between cataract surgery and LASIK surgery? So I'm just going to quickly go over that. So, getting back to like people want to prevent wearing glasses. This is, as an eye surgeon, how we get people not to wear glasses. So people sometimes confuse the term LASIK surgery and cataract surgery, and they don't want to have cataract surgery, they want laser vision correction because they know that's the one that is good. So there's, sorry about that. So this is, cornea working. Okay, so there's two main focusing elements of the eye. There's the cornea and the lens. And they focus light onto the macula in the center of the retina. That's a part of the eye that is macular degeneration. And if you reshape either the cornea or change the human lens and put another focusing element, we can make it so that people don't need glasses anymore. It's going to minimize the need for glasses. LASIK surgery is an operation on the cornea to replace the human lens with an artificial one. So that's the difference. It's a different part of the eye, different operation. And lastly, how often should my eyes be examined anyway? And that really depends upon how old you are and if you have something wrong with your eyes. I would say for the average adult who has healthy eyes, every 3 years, something like that, mainly screening for glaucoma, and yeah, maybe being trouble. A child, once they're sort of screened and they see well, we don't really ask to see them at any specific time. So hopefully your eyes will now become healthier.
All right, so thank you, Dr. Sauls. Just want to let everybody know we will be doing Q&A, but we're going to do it at the end of the event. So please keep your questions in the back of your mind. Also, because we are a Jewish organization, we will be going right to left with our doctors for today. So next we have Dr. Leventhal. Let's give a warm round of applause for Dr. Leventhal, please.
Hi, everybody. My wife warned me to keep something in my hand so I didn't look like Beto O'Rourke speaking. I told her I would. I'll keep a coffee cup in my hand. I'm going to be speaking about hypertension, and there are handouts for you that I just want to spread around. And, you know, hypertension or high blood pressure is considered the silent killer. And the reason is that when your blood pressure is elevated, you really don't feel it. And what blood pressure is the heart pumps an amount of blood against the arteries in the body. And that pressure that it pumps, the top pressure, or the pressure that is, we call the head pressure, that comes out of the heart is called systolic blood pressure. And when the heart relaxes, it's called diastolic blood pressure. And what happens is, as the blood pressure rises, it pounds the inside of the arteries of the brain, the eyes, the coronary arteries, the large blood vessels in your belly, the blood vessels in your legs, and it causes inflammation. There are many reasons that we get inflammation, but high pressure on those arteries affect the lining of those arteries and cause inflammation. And when the lipids are circulating around cholesterol, they deposit on those insides of the arteries and cause atherosclerosis. So high blood pressure leads to stroke, vision problems, dementia, heart attack, heart failure, abdominal aortic aneurysms, kidney failure, and peripheral vascular disease. So you can get a heart attack from it, a stroke from it. It really affects the entire body. And as you know, many different societies have been arguing with one another and saying, well, maybe your blood pressure 140/90 is acceptable. And we had a study that was just recently released, and they decided to treat them aggressively with medication to keep their blood pressure under 120/80, and the other group was placed on the standard regimen to keep their blood pressure below 140/90. And they stopped the study early. These were not with diabetic patients, but they had other risk factors. They were a higher risk group. They were older, they had high cholesterol, they had other comorbid conditions. And it turned out by just dropping the blood pressure and being more aggressive in care, you reduced cardiovascular death by 25%. So you had 25% less heart attack, less stroke, less MI, and all-cause death was reduced just by keeping a more aggressive blood pressure. So our recommendations from the American Heart Association and the American College of Cardiology have now expanded what we think normal blood pressure is and what high blood pressure is. So if you see on your chart, you really should have blood pressure below 120/80. And I remember when I was growing up playing as a kid, my blood pressure was 90/60, 100/70. And as I got older, my weight went up, my physical activity went down, my arteries got stiffer, my blood pressure started to rise. And that obviously put me at risk. And when you look at Framingham data, you can see that as systolic blood pressure rises above 115, for every 20 millimeters that it goes up, you have double the risk of dying from cardiovascular mortality. So as the blood pressure rises, you get damage to these end organs even though you don't feel it. There are people that are very sensitive to their blood pressure, and when it is up, they can get headaches, dizziness, they feel different, but in general, it's really silent. So these new guidelines placed 30% more of the population now being hypertensive. You see elevated blood pressure is 120, 129/80, and high blood pressure now is 130 to 139/80 to 89. That's stage 1 hypertension. However, we really believe that most of the people that are now have elevated blood pressure can be taken care of with weight reduction, with reducing the amount of salt in their diet to about 1,500 milligrams a day, regular physical exercise, really changing your diet to more fruits and vegetables and whole grains, meditation. Alcohol is a big one. Alcohol raises blood pressure. I know that there's a lot of data that's out there that 4 ounces, maybe 2 glasses of wine a day raises HDL, it's cardiac protective. That's not the way the American population drinks. And there's a lot of calories there, there's a lot of weight gain there. So it's risk versus benefit ratio with alcohol. Also, you have to see what 4 ounces of a glass of wine is. It's a very small amount. And if you go out into the restaurants, you'll see that people are probably drinking double and triple that amount. And then, obviously, smoking is the #1 thing to avoid, and stress relaxation is very, very important to lower blood pressure, relaxation, music, breaking away from the routine of daily life is very helpful in trying to keep your blood pressure down. And for individuals that, in spite of doing this, or you're doing the best that you can, and your blood pressure is still elevated, you need medication. And many times, one medication is not going to be enough. You need a combo med. You need at least 2 meds that will be effective in lowering your blood pressure to below 120/80, or at least keeping it at 120/80. I'm going to leave you with one last note of how you take blood pressure. There's been a lot of studies out there. You should be using your own automatic digital blood pressure machine. Data has shown that taking your blood pressure at home is actually more accurate of what's really going on in your body than just taking it in a physician's office. You should be sitting for 5 minutes. The automatic digital blood pressure machine should be standardized, and you should keep that level at the heart level. You press the button, it'll take a pressure. You repeat this 2 or 3 times, you take the average, and that's your real blood pressure. And then you write that down. That should be done in the morning, and it should be done before dinner. And now they just did a study with 9,000 patients, again, looking at blood pressure in the office. And if you come into a doctor's office and you don't see a doctor and you don't see a nurse, and they put you in a room and they give you an automatic digital blood pressure cuff, and you sit there for 5 minutes, that will be very similar to your real blood pressure on the outside. Hopefully we'll transition to that, because some of the machines that we use manually, they need to be standardized on a regular basis. Person comes into the office, the first thing you do is sit them down and take a blood pressure. They haven't had a chance to really rest. So we found that by doing it that way, we get rid of white coat syndrome, that 10 to 20% of the population that walk in and their blood pressure is extremely elevated. That would help in preventing that. The most sensitive and specific test to really know about your blood pressure would be a 24-hour monitor, where you take your blood pressure throughout the day once an hour, and that's probably correlates the most accurately for what's going on with your blood pressure. I'm going to stop.
Thank you very much, Dr. Leventhal. In other news, the wine tasting for next week has been canceled. Next we have our wonderful chairs, Dr. Eric York. I know there's one new parent in the room who will find this especially enlightening, I hope, and I know many of you have grandchildren, so thank you so much, Dr. York.
So just to have what Mark had to say, that affected the pediatrics, and we take blood pressures when the kids come in, and they're off the wall. Then when we find out they're not getting shots, take it on the way out, and their blood pressure is, but it is true, it's very true. So talking about preventative health care, as a pediatrician, we have to talk about vaccination, immunization, which is probably had the greatest impact on public health in the 20th century. There were all these diseases we've all heard of, we don't see anymore. Before immunization, I just have some numbers, there were 500,000 cases a year of measles with 500 deaths a year. There were 200,000 cases of diphtheria a year. Who's worried about diphtheria anymore? 16,000 cases of polio, 150,000 cases of pertussis, whooping cough every year. Well, smallpox has been eradicated. Polio has been almost eradicated. Measles, mumps, rubella, tetanus, diphtheria 99% decrease in how much we see of those. One of the ones we still have issues with, whooping cough, still a 90% decrease in those, in that. You know, vaccines have decreased disease, death, and disability, but they've done many things as well, including what we call herd immunity. You may have heard of that term. It's a term that's becoming better known. And herd refers to as in a herd of cattle. So to protect a community, you don't have to immunize the entire community. You need to immunize about 90% of the community, and that will keep disease out of the community. So that's important for a community to be protected because it protects infants who can't be immunized. It protects people who have cancer, people who are on chemotherapy, people who have poor immune systems. So the idea of immunization is not only a personal one, but it's become a community-wide, of a community importance in terms of dealing with protection. We're in an era where we're dealing with a lot of vaccine hesitancy, though. I found a great quote that said, "Vaccines don't save lives, it's vaccination that saves lives." Vaccines have become a real easy victim, and the MMR has come under fire because of thoughts of autism. Mercury in vaccines has been attacked as being a problem. I can only tell you that everything that's ever come up in terms of vaccine safety being an issue has been scientifically studied and basically shown to be a non-issue. And that vaccines are safe and important and basically save lives. Interestingly enough, the two vaccines that I just wanted to talk about briefly are the ones that are least utilized and will actually cause more deaths than any of the other diseases we talked about. Flu is responsible for 50,000 deaths a year. And the rate of flu vaccine compared to the other vaccines, which is in the 85–90% category, flu is generally under 60%. Now, we do know the elderly are very good at getting their immunizations, but younger people, and certainly even in pediatrics, we get about 50–60% of our kids immunized. There will be 100 to 200 pediatric deaths a year because of flu. And some of those children are sick, but many of them are healthy, otherwise healthy children. It's been shown flu vaccine saves lives. It's also shown and people will say, well, I got the flu vaccine and I still got the flu. Well, it is true, the vaccines are not as protective as we wish it was, but it's been shown even when one does get flu, if you've gotten the vaccine, you are much less likely to be hospitalized and much less likely to die if you've gotten the flu vaccine. The other vaccine that many of you may know a little less about is the HPV vaccine known as Gardasil. That prevents against the virus called human papillomavirus. Human papillomavirus is the cause of cervical cancer in women. It's also the cause of other types of genital cancers and oropharyngeal throat cancers, but the main one is cervical cancer. 14 million people a year will contract HPV infection. Not everybody is symptomatic from it, but 14 million a year will contract the virus. 12,000 women a year will be diagnosed with cervical cancer. 4,000 women a year will die of cervical cancer. Almost entirely prevented with this vaccine. The problem, of course, is when one gets infected, you won't get cervical cancer until 20 years later or so. So people don't think about it, people aren't aware of it. We are working very hard at getting our teenage population vaccinated. I know Dr. Hirsch is going to talk a little bit more about that, and Dr. Lapidie is going to also spend a little time on other immunizations. So, and I'll be happy to answer any questions about that at the question session, because I know that's usually an interesting topic for people. I just also want to talk briefly about sleep. That's another thing we deal with is pediatrics. As we know, a lot of us don't get enough sleep. We certainly know that our teens and young kids don't get enough sleep. Basically, it's the numbers that are used. 7 out of 10 teens don't get enough sleep. 6 out of 10 young children don't get enough sleep. Sleep, when we're sleep deprived, we can't concentrate as well. We're basically tired. Children get irritable. Children don't do well at school. Lack of sleep is even being shown to be associated with obesity and depression as well. How much sleep do you need? Infants, 12 to 16 hours a day. 1 to 2 year olds, 11 to 14 hours. 3 to 5 year olds, 10 to 13 hours. 6 to 12 years old, 9 to 12. Teenagers, 8 to 10 hours a night. Adults, basically also 8 to 9. Signs of too little sleep include, needs to nap, difficult to arouse, irritability, and in kids we see poor grades, and that's really one of the main issues. In order to sleep, there's a term which I think is great. It's called sleep hygiene, and a lot of us do that without realizing it. We certainly think about it with young kids. So young kids, warm bath, quiet time, read to them, give them a little stuffed animal or blanket, and that's a great routine for little kids to get to sleep. The problem is really with teenagers who don't get into that routine, but consistent sleep is important. And the biggest culprit for teens getting to sleep is screens. Screens emit a certain type of light. Dr. Sauls alluded to it, blue light. And blue light apparently messes with our natural day and night internal clocks. So they mess with that, and blue light before one goes to sleep definitely interferes with sleep. So the word out there is there should be no screens a half hour to an hour before sleep. The other things that are recommended is exercise during the day, not right before sleep, but exercise makes one more tired. And also dark, even for teens, some quiet, dark time, either meditating, reading, soft music. Those are the techniques that really do help teens get to sleep more easily. Oh, and also lack of caffeine.
Thank you so much, Dr. York. Again, please get vaccinations. I think that pretty much will be covered more and more. Thank you so much, Dr. Francesco Lavadia, for joining us today from Martinsville Family Practice, and let's give a warm round of applause for Dr. Lavadia.
Just to comment on one thing that the court said, the flu. You get a lot of this. I got the flu shot, and then I got the flu. If you're concerned about that, there is a vaccine. We used it this year in the office. I got it myself. It's called Flu Block. It's a recombinant vaccine, so it's not grown in chick embryos, so you don't have to worry about egg allergies. And it's basically a synthetic made vaccine. I guess they make a part of the virus, and then just like the other vaccine, then they make it alive. I want to talk briefly a little bit about diabetes. It's a big deal, and we see a lot of that in our practice, and we see a lot of. But I don't want to talk necessarily about treatment. Obviously, it's too late, and it's not that you necessarily can prevent it, but at least you can pick it up early and maybe do some things to, to make it give you less problem later down the road. I don't have recent stats, but as of 2017, 23.1 million in the U.S. of diabetes, which is comprised of about 8.5% of the population. And most of it, I'm not going to talk about one, but two, 95% of type 2. So you come to my office and your blood sugar is 110. Are you diabetic or not? Which leads me to my other stuff. What do you think?
Yes.
What's the answer? No?
I don't know, yes.
It's a tricky question, so actually, not necessarily. So what happens is, so your blood sugar is 110, it's above the 100, which is most lab use now. Actually, up to 110, 115 is okay, but that theoretically does not make you diabetic. So, and that's why lately, over the last few years, I don't know when, but we've been using A1C. You may have heard that word, A1C stands for glycosylated hemoglobin. I want to explain to you what that is, because you hear the same thing all over. And don't worry so much about the number, but basically, what an A1C is some smart guy figured out somewhere, your sugar binds to the hemoglobin in your blood, so, and depending how much your sugar is, it binds so much, and you can actually measure that percentage. Now, why 3 months? We measure every 3 months because, again, you know, smart guy, the red blood cell, the life of the red blood cells is 3 months. So if you come to my office and your blood sugar is 110, but your A1C is, let's say, 5.4, you're not diabetic. You were just 110 that day, you know, which people can be. However, if you come to my office and your blood sugar is 110 because you're fasting and your A1C is 7, automatically you're diabetic. You know, and I'll give you the numbers for, so less than 6.5, I mean less than 5.6, you're not diabetic. 5.6 to 6.3, it's considered as pre-diabetic, which is where detecting it early is the important thing. And then above 6.3, you're really a diabetic brain. Now, a couple other things. So to go back to fasting, to answer your question, so if you're 126 or higher, and you come to my office and you're fasting, you're diabetic. If you're 2 hours, it doesn't matter what you eat. If you come to my office 2 hours after you've eaten, whether you've eaten a cake, whether you've eaten, you know, a roast beef sandwich, whatever, if you're greater than 200 and you come to my office, then you're diabetic. So those are easy diagnoses to make. And then I told you about the A1C. Now, what I want to stress is this: it's easy when somebody comes in, they're losing weight, they're urinating a lot. Obviously, they have that body habitus, and you know, to pick up diabetes. But it's really too late. There's about the 5 to 6 years before you get to the point where you can actually pick up somebody early on and then let them lose weight. You know, do lifestyle changes, which either would delay you getting it or at least treat it early. The reason that's important is this: when the pancreas, not to get too technical, but the pancreas secretes insulin, and what happens is, that's the other question I want to ask you. If you have a type 2 diabetic, do they have little insulin, or do they have too much insulin?
I think it's a trick question, so I'm gonna say too much.
Too much, right. So what happens, you're diabetic, you're this term saying insulin resistant, so your pancreas just cranks out, produces more and more and more and more insulin, and eventually it kind of tires out. And that's when people have to, you know, then start being treated. So if you do it earlier on, change your diet, you know, like Mark said, you know, decrease the weight. A lot of the risk factors for hypertension are the same for diabetes, then you actually slow down the progression. You know, it is a familial thing, so, you know, we may not have a choice, but if you pick it up a lot earlier, you know, then we can do something about it earlier. So really, basically, know where your you should know where your fasting is, but also A1C, and obviously family history plays a big part. Both my parents have it, and, you know, I'm already on my way, so I'm trying to exercise a little more. So that's enough for diabetes. We can ask questions later, but I want to talk about this. You hear this thing DTaP or Adacel, or my kids are having babies, and the OBGYN says you got to go get a pertussis shot, right? So first of all, there's not such a thing as a pertussis alone immunization. So you understand when you go and get the pertussis booster, you're really getting what's called a Tdap or an Adacel, which is basically tetanus attached to a quarter of pertussis, which you got when you were an infant. So when you're a little kid, you get pertussis vaccine, which is combined with your tetanus and diphtheria. When you get past 7 years old, used to be the old way, then you got regular, just tetanus and tetanus and diphtheria. What happens is, like Dr. York says, there's been a resurgence of pertussis cases, you know, in this country. So when you, everybody, and the other thing happens is that people get multiple of these and you don't need it. So if your kid's 11 to 18, you need one Adacel booster to boost your pertussis, which you had as a little chunk, you know, when you were an infant. As an adult, you need one anywhere from 19 to 64. And then greater than 65, only one, you know, and then the rest of the time you just get regular tetanus. So I didn't confuse you. The other vaccine I want to talk about is pneumonia. There's 2 vaccines out there now for pneumonia. It's the old Pneumovax, which you may see as Pneumovax 23, which was the old pneumonia vaccine. And then there's a new one, which you may have seen on TV, which is Prevnar 13. they're not boosters of each other. What they are is two separate vaccines, and they cover two different strains. So Prevnar 13, we give it to infants, Dr. York knows about this, but in adults, you really only need one dose after 65, and then you're done. It's not recommended before 65. The old pneumonia, if you've had it before 65, then you need one booster after 65, like 5 years later, just to boost you up. The last thing I want to talk about is shingles. So I have another questions for you. So if I have shingles, can I give you guys shingles? Because this comes up a lot in the practice.
Yes. Yes.
Just answer, just consider the question. If I have shingles, can I give you shingles? I'm not talking about chickenpox. Can I give you shingles?
Yes.
As a gift.
So that's incorrect. So and that's why I wanted to talk about this, because it happens a lot in my office. So just let me take you back. You get chickenpox as a kid, right? Chickenpox is a herpes virus, whether you knew it or not, just like the other herpes. And these viruses just hide in your system, you never get rid of them. Just like when people get herpes 1, which is and then herpes 2, which is really genital herpes. That's why they get reactivation. So what happens is you get chickenpox as a kid, you get better. That virus actually hides in the posterior horn of your spinal cord, basically in the back of the spinal cord. You get stressed, you get chemo, you get other things that reduce your immune system. That virus actually reactivates, erupts onto your skin, right? Because that's what's so painful. It literally just comes along the nerve, it surfaces through the skin, and that's the rash that you see. And it causes all this pain, during and after. So you cannot give shingles or zoster, shingles to shingles. Now you can give chickenpox to somebody who's not had chickenpox if they come in contact with the virus and with blister. But otherwise, so if you have shingles and it's covered, and you're spending time with your family, they're not going to get it because it's not something that you can give for them. So, but just to tell you how important, 30% of patients here, 30% of us here will have shingles during our life, at some point in our lifetime. That's how common it is. It is on the rise. We don't know why. And so there's two vaccines, an old vaccine, which was Zostavax, which was available in the past. There was one injection, which, some of you may have gotten. And there's a new vaccine, which is the big hub now, this shingles, which is, it's a non-live vaccine, so you cannot get the disease from it. And the problem now is that there's a little bit of shortage from the company to getting it, but you get one dose, and then you get a second dose between 2 to 6 months later. The thing about this vaccine, and the FDA actually pushed it through, is the old vaccine was about 50% effective. This vaccine, in some studies, 94 to 97%. Now, if you come to my office tomorrow, I actually don't have it, because like I said, there's a shortage, but once it becomes available, and the age is greater than 50 years old, should get it. And I know Alan already spoke, and actually my wife had it right here on the scalp, and the problem with shingles and the eye, and Alan can comment on this a little bit more, but if it gets into your eye, you get this herpetic keratitis. Basically, it cloudies the keratin, which is in front of the lens, and what happens is the vision gets cloudy, and you cannot reverse that. Whether you use drops or not. So those are the things I wanted to talk about. So.
Thank you so much, Dr. Lavia. Please join us for our next panel, which will be exclusively my personal trainer, followed by my therapist. So, next, I think just one thing I wanted to add is, if you've noticed, when I spoke to the doctors, we spoke about, we wanted to talk about routine preventive care. I feel like there has been one thing that has constantly come, which is vaccination. So please consider it. I would like to introduce our next panelist, Dr. Mark Medalic, joining us from River Valley Dental. Thank you so much for joining us, and please give a warm round of applause to Dr.
I'm of all of us up here, I'm the one you guys should be seeing every year. So let me start this off. My wife made sure I did this. I want to thank Dan for bringing this medical group together. Right? I think it's unusual that you included a dentist. People usually don't think of us that way. You know, it's very true, but I think what a lot of people don't understand is that the oral cavity is the opening to all of our bodies. Right? And everything we put in here has an effect on us. Everything we're exposed to has an effect on us. So seeing your dentist is very important. It's become more and more interesting what we can see from your mouth that may have physiological effects. I think every year there's at least 2 people that, like, in a regular exam, they find they have high blood pressure, right? And they end up going on and having to be on medication for it. So, you know, this is regular dentist visits. You know, it's a big deal. I'll get my teeth checked out. It's not. I did like the high blood pressure thing going to doctors. Ain't nobody close to the dentist. I'm telling you, it is really funny because I mean, people go into the dentist's office and they're just, you know, like the stress levels. It's not here. It is here. And you can, and we actually check blood pressure very often if somebody is high at the end of the visit. And shots are a big issue. People are very afraid of shots. There is technology, by the way. We just got it in our office that there is a laser now that has the effects. The first laser has been approved to be used on hard tissue and soft tissue. And its effect is it has a numbing effect on the tooth. So you can actually have a tooth drilled on with lasers, and it will numb the tooth. Not 100%, but to the point where it's comfortable. It's not totally uncomfortable, you know, and something where probably 90% of the people, of the patients in the practice that have used it, will sit there and they'll say that, yes, I felt something. Well, next time we'll be like, no, nothing. I'd rather not have a shot. I'd rather not be numb for 3 hours. And it's you know, interesting to me that people are that afraid or that uncomfortable with being numb. So, as with all of us, there are technological advancements happening everywhere. Dentistry is really not cutting edge, but you know, dentists are really trying to get their education. There's a lot of improvement on how we treat everyone and how we can take care of our mouths. Seeing your dentist twice a year is important. I go to in February Dental Health Month. I go to 7 schools talking to kids about teeth. This is always easier talking to them than you guys. But I like to make the point to them that, you know, when it comes to home care, brushing and flossing is critical, and it's not that big a deal. You know, if you need to brush twice a day, you need to floss. So every day has 24 hours, right? And there's 60 minutes in an hour. So every day has 1,440 minutes. Okay? You brush twice a day for 2 minutes. I walk, sorry. Twice a day for 2 minutes. And you floss once a day for 1 minute. That means of that 1,440 minutes, you don't have to think about your teeth for 1,435 minutes. All right? We all have time to brush and floss. All of us do. And there's no such thing as after. The best way to make sure you do it is to get an electric toothbrush, which is much more effective because people don't know how to brush your teeth. And they have usually 2-minute cycles on them, okay? Oral-B has a 30-second cycle, so all right, 30 seconds here, 30 seconds, 30 seconds, 30 seconds, okay? And then you floss. Is one toothpaste better than the other? No. Is one floss better than the other? No. When I was in school, I can remember the dentist said that if you just have a toothbrush that has strong bristles, you know, you need to change them when they start to get weak. And thread, you can take care of your mouth. All right, you just have to have a good technique. You have to keep the plaque off your teeth. What happens, and we're talking about signs of systemic issues, and one of the things that we notice is that when people have health issues, the gums get inflamed more easily. And if you're efficient in bacteria that's in the mouth, when they've done research on it, and they have found bacteria, oral bacteria, in hearts and in different organs when they've had done biopsies on them afterwards and checked the patients, that there's actually bacteria that's made into the mouth that can get into your system if you're not cleaning your system, if you're not cleaning your mouth well enough. And keeping that bacteria out. What happens with plaque and bacteria in the mouth is that when you eat food, the byproduct can sit on the tooth and form plaque, which is a layer of paste, so to speak. The bacteria in your mouth, which there are billions of bacteria, you can't do anything about it. And it's supposed to be, it's all part of digestion, it's all part of how your system works. And it's throughout the whole system. It's just how our bodies work and function. The bacteria that's in your mouth settles in on the plaque, and it gives off an acid. Its byproduct is an acid. And that acid creates cavities, it softens the enamel, and if it's left there long enough, it goes into the enamel and creates decay. And it also contributes to problems with your gums, and leads to gum disease. And periodontal disease is the situation where the plaque is in the bacteria is in your mouth long enough in the gum itself, causes gum to swell. Your gum swells because your body says there's a problem. And so what it does is it sends extra blood to the area. The cells in our body can fight the infections, but it doesn't know that it can't get through the gum to get to the bacteria, that bacteria. So when you floss, it kind of ruptures the gum and makes it bleed. The point of that is, if you're brushing your teeth and flossing, if the area bleeds, do it more. Spend a little bit more time there, get that plaque away from there. But related to all of this, start this thing at the dentist and get your teeth clean. Make sure your teeth are clean. And then if you have plaque and hardened plaque, which is called calculus on your teeth, you're going to have irritation, and you're going to have it, so it's going to be bleeding until you remove that first. So get to your dentist and get your teeth cleaned twice a year. Okay? There are minimum twice a year. By the way, twice a year was an 1870s Pepsodent toothpaste ad. It said use Pepsodent toothpaste, good for your teeth, and see your dentist twice a year. All right. Research has shown though that twice a year, generally speaking, is good enough to go see the dentist. Okay. It has much more to do with your overall health on how often you need to see the dentist. Most people, twice a year is okay. There's a large percentage though that it's not. 2 or 3 times a year is necessary for most. And those are people that have periodontal disease. Periodontal disease is irritated gums and loss of bone structure because of the acids that the bacteria will not be giving off. So it's just very important that you are seeing your dentist. There are ways to fix your teeth. One of the things about, especially when we're with our kids, younger kids, get them to the dentist, have sealants put on the grooves of the teeth. Most of our parents, when we look at our parents, have dentures. Okay, the anatomy of the teeth, there's grooving in the top of the teeth. When the parents talk about, dentists talk about having sealants on the teeth, you're trying to seal those grooves. Some of the grooves are so deep that no matter how well you brush, bacteria is going to get down there. Okay, I have my office a laser that can evaluate the bottom of those grooves and say, there's a problem right here, and so we can go right to that spot and deal with that problem while it's small. And it helps a lot with kids, and that works around natural teeth, and also we can find out around the white fillings. We can find out when that junction of the filling is starting to fail, and we can go right to that spot and fix that spot rather than fixing the whole thing. Cavities don't show up on an x-ray until 1/3 of the tooth is soft. 1/3. So you need to start getting there and having dentists that have the diagnostics to be able to find these issues and find them before. And the reason why it doesn't show is because you have x-rays are two-dimensional. There's no depth to an x-ray. So 2/3 or more healthy tooth masks the decay. Okay? So you don't see that on the film until there's other ways to find it. And a lot of it is pulling in teeth and the lasers that help determine it. But it's just very important that you are seeing your dentist for all of this. Okay. And there's other things. There's other issues about technology that's out there that makes going to the dentist a lot easier. Solar laser is one. You can make crowns and teeth, which are necessary in larger fillings. You can make them at the dental visit. A machine called a CEREC. There's new ones out there that you can actually have a tooth prepared, scan with a computer, and have the filling or the crown made. You put on within 20 minutes after you were there. There is
What about oral cancer screenings? How how often should you have that?
Well, the oral cancer screening is every time you come in. Whenever you get your teeth cleaned by the hygienist, people say, well, you know, the hygienist looked at me, why do you have to look at me again? And you have two sets of eyes looking in your mouth for signs of oral cancer. Unfortunately, when I was in dental school, when I was on the patient side, I saw I had a sore in the mouth that turned out to be oral cancer. And he had to have from here to here resected in his jaw. And he survived, but he had to have that portion of his jaw resected. Unfortunately, I prayed I never saw it again. Last year, though, the immunity exam, we found oral cancer under the tongue of a gentleman. And he ended up having that surgery in his tongue. The cancer metastasized, got into his pancreas, and he just recently died. And this was found by us, by a dentist, doing the oral cancer exam. So it's very important that you are, it's not just for your teeth. Blood pressure, signs of diabetes, you can see it gives symptoms in the mouth of oral cancer. So, you know, it's very important that not only we're seeing those physicians, and that's the other thing. Most of why we see so many physicians is to find after something started, after the pathology has started already. And trying to see the dentist when you're younger and all, at least you can try to catch things, nip them in the bud, and try to get them, you know, try to help you, keeping your mouth and your oral cavity healthy. Okay? Thank you very much.
Thank you, Dr. Patel. Correct me if I'm wrong, I believe actually just won an award for one of the best dentists in Hunterdon County, so an award well deserved. Dr. Patel also was kind enough to bring giveaways, so I don't want to take time from Dr. Hirsch, but please, before you go, please take a care package on the way out. So then, last.
It has toothpaste, toothbrushes. Once you just try this. And floss.
Our final speaker for the panel, before we do a Q&A, is another one of our chairs on my side, the very awesome Dr. Hirsch, representing the Women's Care Source. So Dr. Hirsch, it's going to welcome.
Thank you, Dan. So as the chair, co-chair, I want to thank Eric York, my co-chair, for helping me with this event, Dan for just pulling it all together and all of his hard work, Robin Missionary, Executive Director at the Federation, for supporting the Maimonides Society. And just so you all know, the Maimonides Society is a group of health providers in our community that really cares about the health of your community. You can find a list, directory of our providers outside. Please spread the word. When you see these events, we'll be trying to do at least 2 a year for the community. And I'm just so thankful that you are here to join us. I also thought it was very interesting that I got to sit next to Frank Labadie. The last time I sat at a table with him, we were taking medical school exams. So, it was very nice to sit at a table and not have to take an exam. And I found it very interesting that Dan put me next to the dentist because we are probably the most hated. I shouldn't say hated, but blood pressure is highest in our office. So I hear, oh, the only one I hate more than you is the dentist. He probably hears the only one I hate more than you is the gynecologist.
More than once.
So I'm thinking we should just maybe open a practice together. You're all up here, I'm up here. We get it done. So I know not all of you have the parts that I'm going to talk about today, but you all have someone you know and love who does. So routine gynecology care starts around age 21. But it can happen anytime before that if there's a question. And so what happens? So at that first exam, that's when I have an opportunity to teach a young woman about her body. I do, Vulva 101. I don't know if any of you take mirrors, but I have mirrors and I tell people what their parts are because your parts are important. Pap smears. There's a lot of questions about Pap smears. So Pap smears are a screening test where we take cells from the cervix, that's the mouth of the uterus, and look for precancers. That's what we really are hoping to find, not cancers. And when the Pap smear test was first discovered, we took the rate of people dying from cervical cancer went from 90% dying to practically no one dying from cervical cancer. And that was great. We still didn't know what caused cervical cancer, so we recommended Pap smears every single year. Well, it's really interesting. You've heard now about HPV a few times, right? So you've heard it from the pediatrician, you've heard it from our family practice caregiver. The mouth cancer, most likely, that you found was HPV related. And Now we know that HPV is a virus that's transmitted sexually, and it's incredibly prevalent. And we have not only discovered which virus strains are associated with cervical cancer, but we've already developed a vaccine for 9 of them. Some of them that cause warts and some of them that cause cancer. And so now we're not only able to do the pap smear and look at the cells, but we're able to figure out if there's HPV there. So we're able to take our patients and know who's high risk and who's low risk. And if you're low risk, that means that your paps are normal and you don't have HPV. So your chances of developing cervical cancer in the next 10 years is close to 0. Does it make sense to do a pap smear every year on you? Because we're going to pick up more falsely positive smears than falsely negative. But if the HPV comes back positive, you're someone we really have to pay close attention to. And that's the group that we'll still pap every year. Does that mean you don't see the gynecologist every year? Absolutely not, because things change. HPV, just like the shingles, just like the herpes zoster virus, can be dormant. So 1 year it may not be present, and then the next year it may be. It still will take 5 to 10 years for it to cause a problem, but you want to know if it's there. So you still need your exam every year, you just don't need your pap. So that's why your doctors are telling you you don't need a pap every year. It's not because insurance won't pay for it, it's because it really isn't necessary if you're at low risk. Now, we assume everyone's been exposed to HPV. In fact, we don't even look for it in our patients between 21 and 29. We just figure you have it. It's only a problem if it causes the cells to be abnormal. So that's why starting at age 30, we're looking a little more carefully. At age 30, your paps are not just the cells, but they're looking for that virus as well. So anyone over 30 who gets a pap, you're getting those 2 pieces looked at. Now, vaccines originally were only approved up to age 26. It wasn't because they weren't effective up past age 26, and it wasn't because they were dangerous past that time. It's just that the insurance companies didn't think it was cost effective to pay for it after age 46. But the studies actually were up to age 45 and found to be effective up to age 45. So I'm going to ask you to share with your friends and family that anyone who has not gotten the vaccine and who's not 46 or older really should consider getting the vaccine, even if they're in a stable relationship. Life events change and people can be exposed to more viruses. The next question is breast exams and mammograms. Mammograms should be done every 1 to 2 years after age 40. That's a decision that you make with your gynecologist. Imaging studies before then, it's a decision you make with your primary care provider, your gynecologist, your family practice provider. Breast cancer risk assessment should be done yearly on everyone so that I know if I need to send them to talk to Elizabeth and get more information about that. Now, something interesting, and I'm just going to mention this to you, Dr. Malik, is I've learned that patients either do breast exams or floss, but they don't do both. And I don't know why, but I'd like you to start asking your patients, and maybe we could collaborate and write a little paper. For some reason, it's one or the other.
My guess is there's more breast people doing
It's easier for me to ask if someone flosses than for him to ask if you do breast exams. I still think it would be an interesting study. STI screening, so they're not sexually transmitted diseases, they're infections, and they should be checked in anyone younger than 25 and anyone who's in a new relationship. There's a rising problem of sexually transmitted infections in our community of people who are 45 and older, women who are not getting their periods think, well, I can't get pregnant. Well, you can still get the cooties. And so remember to think about that too, because you're not at risk just because you're more grown up. So that was kind of the things that I wanted to make sure to touch